The next presentation is entitled Preoperative Anemia is Associated with Poorer Postoperative Outcomes in Patients Undergoing Infrainguinal Bypass Surgery, presented by Dr. Kim on behalf of two institutions, Duke University and Mass General Hospital, with Dr. Mohapatra as a senior author.
Thank you for the opportunity to present today. I have no disclosures. So preoperative anemia is an important and modifiable risk factor. There have been several randomized controlled trials that have linked anemia with increased perioperative morbidity and mortality after coronary procedures. And the association of CAD and PAD has been well established, but data is limited on the impact of preoperative anemia on postoperative outcomes after lower extremity bypass for PAD. And this is important because other studies have shown that anemia is prevalent in PAD patients, ranging previously reported from 40 to 70% in this patient population. Therefore, in this study, we want to answer the following question: does preoperative anemia impact postoperative mortality rates in patients undergoing infrainguinal bypass for PAD? We hypothesized that anemia would portend worse postoperative outcomes in this patient population. So in order to do that, data was retrospectively collected from a prospectively maintained database, which is called the RPDR, which gathers data from multiple hospitals across the MGB system. We used CPT codes to identify all infrainguinal bypasses performed from 2010 to 2020, and any bypasses performed for non-PAD indications, such as sarcoma infections, pop aneurysms, traumatic vascular injury, or acute limb ischemia, were excluded from analysis. And then we reviewed our EMR for operative details, postoperative outcomes, and hemoglobin levels. We used the NCI classification for anemia, as previous studies have used this classification system as well. We graded mild or grade 1 anemia as hemoglobin between 10 and the lower limit of normal, which differs between patient sexes. Moderate, grade 2, was defined as a hemoglobin between 8 and 9.9, severe 6.5 to 7.9, and grade 4 or life-threatening anemia was a hemoglobin less than 6.5, but none of our patients met criteria for life-threatening anemia. So a total of 492 patients underwent bypass over the study period of 10 years. Over half of these patients met criteria for mild anemia, an additional 30% fell into the moderate or severe anemia categories. This is the distribution of preoperative hemoglobin levels here. The median pre-op hemoglobin was around 11, with an interquartile range from 8 to 12, or 9 to 12. Patients with moderate or severe anemia were older than those with normal or mild anemia on univariate comparisons, as you can see there. Anemic patients were more frequently female. And not surprisingly, anemic patients were sicker overall, with a higher prevalence of comorbidities such as coronary artery disease, diabetes, CKD, and congestive heart failure. I don't have the slide here, but operative details such as whether we used prosthetic or vein bypass, or whether it was above knee or below knee bypass, did not differ between the groups. In terms of surgical indication, patients with moderate or severe anemia had a higher prevalence of CLTI, whereas non-anemic patients more frequently underwent bypass for claudication. Hospital length of stay after the surgery was longer among anemic patients, and postoperative MI rates trended higher among patients with moderate or severe anemia. Other postoperative complications such as wound infection or hematoma were similar between the groups. Postoperative mortality rates, as defined as being within 30 days after surgery, were similar between groups. Of note here, the two patients who passed away in the severe anemia group were due to cardiac events. In the moderate group, 2 of those 6 were due to cardiac events, 2 were due to progressive sepsis from ischemic limbs. And finally, on multivariable analysis, only 2 factors were independently associated with postoperative mortality. These were male gender and severe anemia when compared to non-anemic patients. Other covariates which we tested included patient age, all the comorbidities that previously listed in surgical indication. None of these were associated with postoperative mortality. Some limitations with this retrospective study. For instance, EBL and blood transfusion data were reported in less than half of the operative reports or discharge summaries, so we couldn't account for that. Another limitation is that anemia may be a marker of frailty. Previous studies have linked frailty with increased risk of postoperative complications and death following lower extremity procedures. But in this study, we didn't have other markers of frailty such as nutritional markers and BMI and recent weight loss, et cetera, to test this hypothesis. So in conclusion, preoperative anemia is prevalent among PAD patients undergoing lower extremity bypass, much more prevalent than previously reported in our patient population. Over 80% met criteria for anemia, and over 30% were moderately or severely anemic. And we also found that severe anemia was a risk factor for postoperative mortality. And finally, the ultimate question is, what do we do about this? I think that we need future studies to help determine whether correction of anemia improves postoperative outcomes, and we need these studies to help determine the optimal preoperative hemoglobin level. Thank you for your time. I'd be happy to take any questions.
And that adds to the morbidity mortality up front already.
Certainly, that's a great question. I don't remember the numbers. It was somewhere around 20 to 40% on the previous slide, which is a significant number, and we have more CKD patients in in more severe anemia, but we tested for that on our multivariable analysis. It just didn't meet the cutoff.
Is that right? Because I think in that population, you probably wouldn't be correcting anemia vigorously on that.
Absolutely.
So, quick question, great job. Can you define, and I might have missed in your presentation, where you got the hemoglobin value from? Was it the first one right before the operation? Was it the lowest in the last 30 days? And if you can comment on your interactions with anesthesia around the idea of tanking a patient up right before an operation like this. Are there a large percent of patients whose hemoglobin hovers in the 6 or 7 and got 2 units of blood right before a bypass?
Thank you. Those are great questions. To the first point, it was the most recent hemoglobin level before surgery. These patients go to see a preoperative anesthesia clinic and have a number of labs drawn and EKGs, and it includes a CBC. So it was the most recent one before surgery within 30 days. To the second point, in terms of tanking these patients up, EVL can be it can be very low before the surgery, and it can be very high. And tanking patients up, a discussion with anesthesia is certainly worth it. But slamming a patient who has congestive heart failure and EF of 20% with a couple units before surgery may be detrimental. So I think it's on a patient-by-patient basis.
Matt Smith, University of Washington. Nice job. Do you have any data, and I'm sorry if I missed this, on what the postoperative hemoglobin and hematocrit were as potentially a surrogate marker for how well these people were resuscitated or how dilute they were afterwards? It's unclear whether or not anemia is a marker of frailty or whether or not we just lost more blood in those cases.
That's an excellent question. We did look at postoperative hemoglobin levels, and we looked at preoperative, postoperative, and we looked at the delta, and we found that the preoperative hemoglobin level was the most significantly different and made the most difference there. The postoperative hemoglobin levels, the average delta was only 0.5 between the.
Yeah, nicely presented. My question was going to be about why you think these patients are anemic. I mean, I think that's what it gets down to, because a lot of patients who are sick have anemia, and there's been lots of studies that show anemia is bad. You'd rather not be anemic if you don't have to be. But, when you think about transfusion, that's a different situation, right? You're giving someone else's blood. That's not clear that that's going to make that better. In the same way that if someone's hypoalbuminemic, giving them albumin doesn't necessarily fix the problem that made them hypoalbuminemic. So I would encourage you to look at whether or not transfusion actually was independently beneficial or harmful in that study. That's what we had published on previously. So I'd like to see if you guys had similar findings.
That's a great point, Dr. Meany. Thank you.
One last question.
Hi, thank you very much. Randy DiMartino from Rochester, Minnesota. I think the comment about transfusions, anemia, morbidity is very pertinent. One question for you at your center, is there a role for, or is there a plan for iron infusion based on certain criteria, and or for more elective cases, a more robust anemia workup and correction done on a maybe longer term basis instead of an infusion of iron? So those are things that we've talked about to both decrease
transfusion needs, because that's been shown to decrease transfusions, but also to try to address the anemia. Thank you.
Thank you, Dr. DiMartino. This is a great comment. That's something we looked at as well, but then we also looked at other ongoing studies on clinicaltrials.gov, and there are studies that are looking at prehaving patients, including replacing vitamin and mineral deficiencies in order to improve outcomes. So we're waiting on the results of that before we can make a more definitive statement here.
Great, thank you.